Hello, I'm a respiratory therapist at Children's Hospital of Pittsburgh of UPMC. Your child's comfort is one of our top priorities. While he or she is in one of Children's Hospital's intensive care units, a respiratory therapist will monitor and support his or her breathing. To help you feel a little more comfortable, I will explain some of the words you will hear the respiratory therapist and medical team use in relation to your child's respiratory care. In the ICUs, respiratory therapists monitor pulse oximetry. We commonly call this a pulse ox, and it measures the percentage of oxygen in your child's blood to let us know when he or she needs oxygen therapy or if his or her oxygen therapy needs to be adjusted. This is a pulse ox and it's painless. It has a very tiny light that clips easily onto a finger or toe. By connecting it to your child's monitor with a cable, the medical team can see that oxygen percentage on the monitor. Every child admitted to the ICU is connected to a pulse ox. Let me back up for just a minute and explain a little bit more about oxygen. Oxygen is the therapy that we give to children when their oxygen levels are too low. There are a few different ways of delivering the oxygen. The most commonly used devices are nasal cannulas, Venti Mask, and non-rebreather masks. A nasal cannula is a very soft plastic loop. It has soft prongs that sit right inside the nose and then loop over the ears. Most children don't even notice it after a moment or two. A Venti mask fits over the nose, mouth, and under the chin, and it delivers a higher amount of oxygen than the nasal cannula. A non-rebreather mask also fits over the nose, mouth, and under the chin and has a reservoir bag. It delivers the highest amount of oxygen. The respiratory therapist will determine what type of oxygen is used based on your child's needs. Respiratory therapists come around several times a day to look in on the children to whom they are providing care to make any necessary adjustments. Sometimes an endotracheal tube, as commonly referred to as a breathing tube, is placed in the trachea, windpipe, to help your child breathe. The tube is inserted by a doctor at your child's bedside, and you may be asked to leave the room since several staff members are needed to assist the doctor. Once the tube is in position, it's secured to the face by tape or by a series of straps called headgear. While the tube is in your child's airways, he or she will not be able to talk. This is because the tube bypasses the vocal cords. The respiratory therapist will assess the tube to make sure it's secure and in the proper position. The breathing tube connects to a mechanical ventilator that allows your child to rest while it breathes for him or her. It has buttons and knobs that will be adjusted by the respiratory therapist based on your child's needs. The ventilator, also called the vent, can and will set off alarms. This occurs because the respiratory therapist sets limits so that any significant changes can be addressed. These alarms are very loud and are meant to be that way so that staff is alerted right away. We have a few different styles of ventilators. They look different but can all function the same way. Many children forget that they were on ventilators once they have left the ICU. Usually, they need a lot of rest when they need help breathing. So we check to make sure that they are resting comfortably. Not every child in the ICU will need all of these devices. Your child's medical team will assess his or her needs and determine the therapies that are most appropriate. Respiratory therapists are glad to be members of your child's team to help in his or her care.